Melbourne, Australia, and senior clinical faculty in the Department of Critical Care at the University of Melbourne. She is undertaking a PhD examining sex differences in the illness, severity, mortality, and treatment of intensive care patients. In 2015, she co-founded the Women in Intensive Care Medicine Network, now a committee of the Australia and New Zealand Intensive Care Society. She's committed to promoting equality in intensive care medicine. And it is my pleasure to introduce her today. Thank you so much for joining us.
Thank you for your introduction. I'll just try and share my screen now. Yes, it's allowing me to do that. Okay, can you see my slides? Oh. Can you see my slides now?
Yes.
Yeah, wonderful. Thank you. Okay. So thank you very much for having me today to speak at the Critical Care Grand Rounds. I'll just check my slides are going to move along. Yeah. So regarding my affiliations and disclosures, I think these have already been introduced. I'm speaking to you from Melbourne, Australia, where I'm undertaking my PhD. I work at Austin Health, and I sit on the Women in Intensive Care Medicine Network, and I have no financial disclosures. And I'd like to acknowledge the Wurundjeri people, who are the Aboriginal people of the land from which I'm presenting today. I pay my respects to their elders, past and present, and I extend that respect to all First Nations people who are here today. So today I'll be talking about sex differences in the ICU patient population. And I'll begin by providing a bit of a broader overview for or some context for this topic, then examining the sex balance within the ICU patient population, giving some evidence for sex differences in critical illness across the domains of illness, severity, mortality, and treatment. And then concluding with some thoughts on what we really mean by sex and gender in ICU research. So it's useful to ask ourselves, who is the average ICU patient? And I can say with some certainty, speaking for my part of the world, for Australia and New Zealand, that the average ICU patient is roughly this person, a 62-year-old man who is admitted to the intensive care unit primarily with a cardiovascular condition. And the trouble with averages is that we don't work in intensive care units that are filled with duplicates of the average patient. Instead, if we walk through our adult intensive care units, what we see is a diversity of patients. So there'll be some younger adults through to the very elderly, people who've come in with a variety of admission diagnoses and with a variety of ethnic or cultural backgrounds and genders. And so actually our intensive care units are somewhat better represented by this photo here on the right, in that they're a group of mostly older adults from a variety of cultural backgrounds and different genders. And this is where I think sex differences research starts to come in, is it's a small step in bridging the gap between treating the average ICU patient to treating the actual diversity of patients that we see in our units, and in particular with the goal of eventually delivering more personalised care to the very specific patient in front of us. So before I go much further, I've probably already used the terms sex and gender, so I'll just pause briefly to define those somewhat. So sex refers to the biological distinction between men and women. Quoted this as the definition provided in the data dictionary of the clinical registry in my country, in Australia and New Zealand. But this definition obviously has an important limitation in that it overlooks intersex people, so people who biologically are neither men nor women. In contrast, gender is a socially based construct related to one's personal identity as a man, a woman, a non-binary person, or a range of other genders. And in ICU research, I think it's worth acknowledging from the outset that we often use the word sex and gender interchangeably. And I think this acknowledges that, in fact, we're often referring to aspects of sex and gender when we talk about this. And ICU research really to date in examining sex differences has exclusively just compared women and men. So there's a real paucity of data on intersex or non-binary people. Now, we've got good reason to think that that sex differences might be important in critical care because simply there are differences between women and men. And I think I'm probably, I've put up some fairly unsurprising or familiar differences. So from a biological point of view, there are important hormonal differences, particularly in the sex steroid hormone milieu between women and men. This in turn drives slight differences in the inflammatory response. There are anthropomorphic differences between the average woman and the average man. And then there's also differences in the normal range of physiological variables to which we refer often in intensive care between women and men. And an example of that would be different normal ranges for blood pressure. There's also behavioural differences, including important health risk-taking behaviour like the prevalence of smoking, and also the level of engagement with healthcare or healthcare seeking behaviours, which is generally higher in women, which may be related to interactions with healthcare during pregnancy. And then to add a third layer to this, this complexity, in addition to the differences I've just listed, women and men are treated differently at times when presenting with the same complaint. And so examples of this include that women with chronic kidney disease are less likely to receive dialysis. Women who have a cardiac arrest are less likely to receive bystander CPR, and when they, if they make it into the hospital, they're also less likely to be taken to the cath lab or coronary angio suite. And women presenting with acute coronary syndromes are less likely to receive timely revascularization and other evidence-based interventions, even simple things like whether they're discharged on statins or beta blockers. And then the final layer of complexity is that I think all of these differences then interact with each other in quite complex ways. And to take just a couple of examples, if we consider the health risk behaviour of smoking, we know that that impacts differently on women and men. It confers differential risks of lung cancer, for example. And then biological differences between women and men also do inform part of the treatment differences that I've just spoken of. So, one of the reasons that women are less likely to have coronary artery bypass graft surgery is that they are less likely to have coronary anatomy that is amenable to bypass grafting. So I guess just to paint an idea that this is quite a complex system. And so it's unsurprising then that we observe significant sex differences in the incidence, manifestations and outcomes of different diseases. And I've listed here some of the diseases where these sex differences are either more prominent or better studied. And for those of you who are interested, here are some references of sort of some major recent reviews on these topics. So I think understanding sex differences, therefore, has the potential to improve outcomes for our ICU patients by two distinct mechanisms. The first is if there are any inequities in treatment, then understanding and working to rectify those has the potential to confer improvements on our outcomes overall, simply because we're looking at two very large demographic groups. Women and men make up close to 50% of the population each. Understanding sex differences also offers the potential for us to deliver more personalised treatment. So, for example, if we find that some critical care interventions have different impacts or gendered impacts on patients, then we can better tailor it to each sex. So let's turn now to consider the sex balance in the intensive care unit. And I'll also define that from here on, when I'm talking about sex balance, I'll arbitrarily define that as the percentage of people within a group who are women. And so if we look at the global population, then it's a familiar fact that roughly half of the world's population are women. Here's some World Bank data from last year. And the sex balance is also reasonably stable across different regions of the world, between about 49 and 51%. And yet when we look within the ICU patient populations around the world, we see that there are consistently more men than women. And this table summarises some of the larger studies that specifically look at sex differences in the ICU patient population. And you can see the sex balance down there in the column on the right. And there's really quite a significant range in the reported sex balance from between 37 and 45% in this selection of studies. And in the systematic review that I'll present to you shortly, where we identified 21 studies from 14 countries, the sex balance sat at about 43% women. And so this observation is really the starting point for my program of research in my PhD is, why is it, how can we understand why it is that 43% of the ICU patient population are women? And so the first thing that we did in examining this further is to simply describe the sex balance according to the admission diagnosis of ICU patients. So we undertook a study setting out to quantify the relative contribution of each major diagnostic category to the overall observed sex imbalance in ICU admissions. And we did this using a retrospective observational study, using the Australian New Zealand Intensive Care Society's adult patient database. And I'll just briefly pause to say that this is a clinical quality registry that's used in Australia and New Zealand that accounts for 90% of all admissions across our two countries, including all admissions to the tertiary unit, so to the large hospital-affiliated units in our countries. In this study, we had a 14-year study period. So that was a study population of over 1.6 million admissions, of whom 42.3% were women. And this equated to, over that 14-year study period, 248,996 more men than women was the overall sex imbalance. So this table summarises the study population by diagnostic categories, which is then ranked according to sex balance. And you can see that there's actually a sex imbalance across most of the listed diagnostic categories. So very subtly, those highlighted in blue are the diagnostic categories where there's less than 48% of patients are women, and those in pink where there's greater than 52% of patients are women. And this figure quantifies the relative contribution to the overall sex imbalance of each diagnostic category, where we define the overall sex imbalance as the absolute difference in the male and female admissions. So it's that 248,000 more men than women. And I think there's two striking things to point out here. First, clearly, most of the sex imbalance is arising from patients who are admitted to ICU with a cardiovascular complaint. So, and of those, most of those are operative diagnoses. So over half of the observed sex imbalance are patients with admitted after cardiac surgery. And yet there are also a number of diagnostic categories that make a really substantial contribution to the observed sex imbalance. So across the categories of gastrointestinal complaints, respiratory complaints and trauma, each of these contributed more than 20,000 more men than women to the ICU over the course of the study period. Next, we looked at a more granular level, so at the level of the individual ICU admission diagnosis, and we looked at those that had the lowest and highest percentage of female patients. So first, this is the list of the top 10 most male-dominated diagnoses. And you can see that this list is composed entirely of cardiovascular conditions and trauma. And the second thing to point out is that across some of these diagnostic groups, there's really a very low percentage of female patients, so fewer than 1 in 5 patients, for example, following some aortic surgery are women. In contrast, the list of the most female-dominated diagnoses is more varied and takes in things like asthma, endocrine surgery, subarachnoid hemorrhage and hypertension, and gastrointestinal obstruction. So really, we found when we considered sex balance in the ICU in Australia and New Zealand that this sex imbalance was quite large and consistent with other countries around the world. We found that this sex balance varies substantially across diagnostic categories of ICU admission, and that cardiovascular diagnoses contribute to over half of the observed imbalance. So the next question that, that we looked at is, what are the sex differences in the illness, severity and mortality of ICU patients? And given that there's really quite a large body of literature addressing this question now, we undertook a systematic review and meta-analysis examining this question. So asking, among adult ICU patients, is there a difference in the illness, severity and mortality of women compared to men? We included observational studies of adult ICU patients, and in particular we included studies that explicitly examined the association between sex and illness, severity or mortality. So we did not include all studies that happened to report sex data. And we also included studies that took in a broad cohort of ICU patients, so across different diagnostic groups, and in particular we excluded studies of specific diagnostic groups, things like studies of just the sepsis cohort or the cardiac arrest cohort. In our statistical analysis, we calculated pooled odds ratios for mortality, comparing women to men, which means that odds ratios greater than 1 indicated that women were more likely to die than men, and vice versa. Following our searches, we identified a total of 21 studies, and this yielded a pooled study population of 505,000 participants, of whom, again, 43% of patients were women. And you can see that the regions represented, really most of these studies were coming from North America and Europe. There were no studies from Australia and New Zealand, and there were no studies from low or middle income countries. These were all high income country critical care units. This very busy table summarises the risk of bias assessment in our study, and I think we can summarise that by saying there was relatively high heterogeneity and few studies at low risk of bias across all domains. So this forest plot summarises the sex differences in illness severity scores, so of women compared to men. And you can see that really their illness severity was assessed using a number of different scores, which were really all different iterations of the acute physiology score and the Apache score. And if we look at the pooled estimate at the bottom, we can see that there was a trend towards women having higher illness severity scores than men. This did not reach statistical significance. So next, if we consider the mortality of women compared to men following ICU admission, again, across the studies, this was recorded at different time points. And I should point out that this forest plot only takes in estimates that were of adjusted mortality, so adjusted for at least one of illness, severity, age, diagnosis and comorbidities. So at 2 time points, we saw that women had higher mortality than men. That's at the point of ICU discharge and at 1 year mortality, 1 year. But at the other 2 time points, so hospital and hospital discharge and 30 days, there was no difference between the sexes in mortality. So overall, this piece of work identified substantial heterogeneity and risk of bias in the existing literature. We found that women tend to have higher illness severity scores at ICU admission, and that women and men are equally likely to die by hospital discharge in 30 days, but they're more likely to die by ICU discharge in 1 year. And one of the implications of this is that there's, it suggests that there's possibly a higher ICU admission threshold applied to women than men across these studies. So I'd like to pivot now and consider this question of ICU admission thresholds or sex-based equity of access to the ICU. And another way of framing that is to kind of reconsider this question of this sex balance of 43%, to say, well, does that represent equitable access to the ICU? Is that a fair balance between women and men? And this is a really difficult question to answer. So the first way of assessing equity of access to ICU is similar to what we've just summarised there, considering illness severity and outcomes. And I'll just highlight to you this paper by Rain and colleagues, it's a group from the UK, that nicely describe this in terms of the concepts of horizontal equity and vertical equity. So horizontal equity exists if women and men are admitted to the ICU at similar levels of illness severity. whereas vertical equity is the idea of unequal use for unequal need. And that really looks at whether women and men have similar outcomes from critical illness. Now, I think these are really useful concepts, and yet, of course, they have a limitation, which is that if we consider only the numerator of people who have actually been admitted to the ICU, we aren't accounting for the denominator of all potential ICU patients or all critically ill patients in the hospital. So here are some other papers that have used different methods to assess equity of access to the ICU. Garland and colleagues, so this nice paper in critical care. This is a group of Canadian critical care researchers, and they assessed equity of access by estimating population-based denominators of critically ill patients to generate critical illness normalised ratios of ICU admission. And essentially that meant that they examined this pool of potential ICU patients who were those who were admitted to the ICU and also those who died in hospital. And of note, this pool excluded patients who received palliative care in hospital, which actually was up to 42% of deaths per year within this cohort. And using this method, they found that the male predominance of ICU patients was accounted for by higher estimated rates of critical illness among men. So I think this is a really important piece of work. Now, in contrast, here's another paper from last year in intensive care medicine that again took the approach of looking at the denominator of potentially critically ill patients. So Todorov and colleagues did this work. This is a Swiss group of researchers. And they had a cohort of 450,000 hospital patients who were admitted with cardiovascular or neurovascular conditions, and specifically it was patients who presented with pulmonary embolism, heart failure, acute coronary syndrome, cardiac arrest, or stroke. And they undertook multivariate Bayesian regression analysis for unplanned ICU admissions, adjusted for diagnosis and age. And in contrast to the previous paper, they found that overall women had a lower likelihood to be admitted to the intensive care unit than men, despite being more severely ill. So in this cohort, the women had higher simplified acute physiology scores than the men. The women had higher unadjusted mortality, and they also had higher adjusted mortality among the group presenting with acute coronary syndrome, although there was no difference in adjusted mortality in some of the other diagnostic groups. And the final way that people have assessed equity of access to ICU was really to go about asking clinicians and critical care clinicians about their thresholds to admit patients to the ICU. So these two papers are done by a Swedish group of researchers. It's the same group, and they've undertaken a series of these two survey studies where they asked physicians to assess hypothetical cases for admission to the ICU, with the participants randomised to either receive cases that were assigned a male or a female gender, and otherwise the cases were matched. And in both of these studies, they did not find any evidence of gender bias, and that the matched cases, male and female cases, I think there were Jane and John in one of the studies, were equally likely to be accepted for admission to the ICU. So, is there equity of access to the ICU between women and men? I think the answer is we don't really know. And so it's possible that 43% is the correct balance. But I don't think we have the evidence to give a clear answer on this one yet. So next, I'd like to present a piece of work that it will be published in the Blue Journal, looking at sex balance and mortality according to diagnostic groups. So I've just spent some time presenting our literature review of sex differences in illness severity and mortality across a broad cohort of ICU patients, which found no difference in mortality at the time point of hospital discharge, so no difference in hospital mortality. And yet, if we go diving into the groups of individual critical illnesses that can bring people to the intensive care unit, we know that there are sex differences. And by way of example, on the left, there are listed some particular critical illnesses after which women are more likely to die than men. And on the right, some illnesses in which women are more likely to survive than men. You'll notice that list on the left, the groups where women are more likely to die than men, being cardiac surgery, burns, cardiac arrest, that maps fairly neatly onto the list of diagnoses in which there's a strong male predominance, where this is diseases that less commonly affect women. So this led to the hypothesis that there could be an association between sex balance in ICU admissions across diagnostic groups and sex differences in adjusted mortality. And in particular, we hypothesised an inverse association between the percentage of patients who are women within a diagnostic group and the relative mortality of women compared to men with that diagnosis. So just to sort of talk you through this, essentially we said in diagnostic groups with a very high percentage of female patients, we were hypothesising we'd observe a relatively low mortality for women, and vice versa. In diagnostic groups with a low percentage of women, we were hypothesising we'd observe relatively high mortality for women compared to men. And our secondary objective was to essentially look at the same association, but between sex balance in ICU admission by diagnostic category and the relative illness severity of women compared to men. So again, we undertook a retrospective observational study using the ANZIC's core adult patient database. We studied a 10-year period of data, and the important exclusions criteria here was that we given that we were considering sex balance across diagnostic groups, we excluded sex-specific diagnoses. That was things like postpartum hemorrhage or people admitted following major prostate surgery, for example. And I think the other exclusion criteria you can read there. So in this study cohort, we had just over 1.4 million admissions, and again, 42.1% of those were women. And we found no difference in the adjusted hospital mortality of women compared to men. Well, sorry, I think I've just skipped a slide. The statistical analysis, I'll briefly speak to this because I think it is important. So how did we adjust hospital mortality in this study? We used a mixed effects logistic regression model, which adjusted for sex, Apache 3 score, admission year, and hospital site. And then we repeated this regression model for each admission diagnosis in our data set, and there's roughly 110 diagnoses, diagnostic groups that we considered. And similar to the previous work, odds ratios greater than 1 indicated that women were more likely to die than men, and vice versa. And then the final step was that we undertook a weighted linear regression to compare the percentage of women in each diagnostic group with the odds ratio for adjusted hospital mortality of women compared to men. So getting back to this slide, so if we looked at our study population overall, there's sort of 1.4 million admissions, we found no difference in the adjusted hospital mortality of women compared to men. And this mirrors the findings that we had in the meta-analysis, taking all those studies from North America and Europe. However, when we started to look within diagnostic categories, we saw that there were significant sex differences in adjusted hospital mortality. So in the cardiac surgery category, the odds ratio for hospital mortality for women compared to men was 1.6. And if we looked across the group of metabolic, renal and hematological disorders, women were significantly less likely to die than men, with an odds ratio of 0.87 for hospital mortality. So this is the key figure from this piece of work, and I'll talk you through it step by step. Essentially, each dot on this graph represents one diagnostic group. So there's roughly 110 dots on the graph. And plotted along the x-axis is the percentage of patients within that diagnostic group who are women, and the dashed vertical line represents the mean sex balance for the study population overall, the 42.1%. On the y-axis, plotted the adjusted odds ratio of hospital mortality for women compared to men. So dots lying above the solid black horizontal line are diagnoses in which women were more likely to die than men, and dots lying under the line were those where men were more likely to die than women. And so effectively what we found was that there's a group of diagnoses up here in the top left corner of this graph in which there are relatively few women within those diagnostic categories, and women are more likely to die than men. And conversely, in the bottom right corner, we can see a group of diagnoses in which there's relatively more women, more than average, and men are more likely to die than women. This next figure plots the association between illness severity of women compared to men versus sex balance. And again, we found a statistically significant association on our weighted linear regression, so that diagnostic groups in which there are relatively few women, we found that women were admitted to the ICU at a relatively high illness severity score, and vice versa. So what are the possible implications of this? Well, really, I think there's two important hypotheses arising from these observations. The first is that this might be a sex-based volume outcome relationship, and certainly we know that sex-based volume outcome relationships are well recognised in critical care. So, for example, units that admit and care for more patients who require ECMO achieve better outcomes than lower volume ECMO centres. And this, so this might be, as I said, a sex-based relationship, reflecting in turn that systems are adapted to more common presentations, and also that that clinicians may recognise, diagnose and treat patients more promptly when they present a condition that's familiar or common for their sex. Now, the second key hypothesis, or complementary hypothesis, is it could be that the exposure of being a man or being a woman over the lifespan leads to sex differences in both the incidence and outcomes of different diseases, different critical illnesses. And I've highlighted some of those sex differences before. So to try to untangle or to understand more what is driving this observed relationship, we undertook a sensitivity analysis where we grouped patients rather than according to their admission diagnosis, we grouped them according to their admitting hospital. And we essentially grouped the hospitals in 48 quantiles which were ranked according to sex balance. So each of these quantiles had roughly 30,000 patients. And you can see that across these groups of hospitals, the sex balance ranged quite widely from about 32% to nearly 55%. And in grouping patients this way across hospital groups, we were able to repeat our regression model, our multivariate logistic regression model, adjusting also for diagnosis. So in these regressions, the odds ratios, or the adjusted odds ratio of hospital mortality here, are adjusted for diagnosis, illness severity, and admission year. And once again, we can see that there is a relationship between sex balance and the relative likely or mortality of women compared to men. So on the top left corner, there are hospitals where relatively few women are admitted and the women are relatively more likely to die than men. And then in the bottom right corner, the hospitals in which there are relatively more men, and the men are less likely to die. So overall, we observed a minority effect, or a sex-based minority effect, that can be summarised as saying that patients who had higher illness severity and mortality, if admitted to ICU with a diagnosis that's relatively uncommon in their sex. And in addition, patients had higher mortality if admitted to an ICU that admitted relatively few patients of their own sex. And this minority effect is bidirectional, it cuts both ways. So women are more likely to die in diagnoses with relatively few women, and men are more likely to die in diagnoses with relatively few men. So what are the practical implications of this? I think a simple takeaway is that as clinicians, we need to really take care, take heed of patients who are presenting with illnesses that are uncommon for their sex. And I think a second implication is that clearly when we look at sex differences across broad populations of critically ill patients, the apparent sort of similarities in outcomes can belie quite marked differences in mortality across different diagnostic groups. And in turn, I think this is a reason for us really to pursue, to always consider sex differences and pursue sex disaggregated data when we're undertaking critical care clinical trials. Okay. So the next thing to consider is we've talked about patients, equity of access to the ICU and how likely women compared to men are to survive their ICU admission. And the next question is, are there sex differences in the treatment that patients receive in ICU? And again, there's a reasonably broad literature looking at this question. So we undertook a systematic review and meta-analysis, and this was published in Crit Care Medicine this year. This meta-analysis was, a paired study or a companion piece to our previous work. So I won't labour our methods beyond saying that we looked at 3 domains of treatment in the ICU. So we looked at the treatment of women compared to men across mechanical ventilation, renal replacement therapy, and length of stay. And again, we calculated pooled odds ratios for receiving the intervention. So odds ratios greater than 1 indicated that women were more likely to receive the treatment, and odds ratios less than 1 indicated that men were more likely to receive the treatment. Here's our included studies, and again, roughly 42.7% women. I'll highlight that one study from the US contributed nearly half of the whole patient's population. Excuse me, and again, there's quite a broad range of the sex balance across these studies. Regarding our risk of bias assessment, risk of bias was most commonly observed across the domain of representativeness. I think if we go back here, you can see there are a few studies there that are really small single centre studies with just a few hundred patients. There was also risk of bias in the comparability domain for several studies, and this was often because the studies were considering sex differences in treatment as a secondary objective and therefore did not adjust the treatment outcomes for important confounders. And then interestingly, the ascertainment of exposure. So in about half the studies, it was unclear how the studies defined sex or gender, or ascertained the sex or gender of the patients, which I think is interesting because these were studies that were explicitly eligible for the review because they were examining sex or gender as their primary exposure. So through to the results of this meta-analysis, and this is forest plot presents the likelihood of women compared to men to receive mechanical ventilation in the intensive care unit, and this includes only adjusted estimates, so adjusted for illness severity, age, etc. And you can see that women overall were less likely than men to receive mechanical ventilation. However, there was no difference in the duration of mechanical ventilation between women and men overall. Regarding renal replacement therapy, again, there's 5 studies that provided adjusted estimates of the use of renal replacement therapy in women compared to men, over 90,000 participants overall in this part, and women were less likely to receive renal replacement therapy than men. Regarding length of stay in the ICU, women had slightly shorter length of stay in the ICU than men, by about a quarter of a day, so 6 hours. But there was no difference in hospital length of stay between women and men. So in this meta-analysis, we found that women received less mechanical ventilation and renal replacement therapy and had shorter ICU length of stay than men. Again, we identified substantial heterogeneity and risk of bias across studies, but of note, our key findings persisted in sensitivity analyses that considered only studies at low risk of bias. So overall, I think it's a really strikingly consistent finding. I'll highlight a couple of other relevant studies of sex differences in treatment of ICU patients. The first I've already spoken of in this talk, so the Todorov paper from intensive care medicine last year. This was excluded from our analysis as it was considered only patients with cardiovascular and neurovascular conditions. But they had very similar findings that women were less likely to receive mechanical ventilation and renal replacement therapy. And of note, they found that women were more likely to receive non-invasive therapy compared to men. And another study from the Swedish group that similarly also found that men were more likely to receive mechanical ventilation, renal replacement therapy, and vasoactive treatment in the ICU. So the important question that we're hopefully all asking by now is why is this the case? Why are we observing that men have received more treatment in the ICU than women? So I'll offer a few hypotheses. I think the first is that it's possible that some of the sex differences in treatment we're observing is driven by sex differences in the normal range of different physiological parameters. And there's certainly a plausible explanation here regarding renal replacement therapy. So knowing that men have a higher muscle mass on average than women, they also have a higher urea or blood urea nitrogen level. And if this is being used as one factor to inform the decision to start renal replacement therapy or start the filter, that could account for some of that sex difference. But there's limitations to this hypothesis too. It doesn't really speak to sex differences in mechanical ventilation, nor length of stay. And I think if we considered that, one of the reasons people commonly stay in the ICU is because might be a lingering vasoactive requirement, and that doesn't really explain the differences that we've observed. So another possible or important explanation is it could be that there are different limitations of treatment in place for women and men. So limitations of life-sustaining treatment or limitations of medical treatment. I'm not sure what terminology you use. And certainly there is evidence to suggest that women are more likely to have a treatment limitation in place. There's a review there, McPherson and colleagues, that report this. And this leads to the question, well, why do they have different rates of treatment limitations? And it seems that it's more likely to reflect the behaviour of physicians as opposed necessarily just to patient preferences. And I say that based on this study by Rubio and colleagues that looked at the origins of medical treatment limitations and finding that only 5% of those were made to reflect primarily the advance directive of the patient. And the majority were made by physicians based on the perceived likely benefit of treatment. So I think this is an important area for future research, understanding sex differences in treatment limitations. And then finally, we return to this idea that there may be unconscious cognitive bias on behalf of clinicians that is impacting the way that we prescribe different therapies or interventions within the intensive care unit. And I think, this is incredibly slippery or difficult to pin down. But if you're interested in reading about systemic bias in clinical reasoning, I draw your attention to this, this reference by Fitzgerald and colleagues, which really looks at the rates of unconscious bias that's observed in clinicians and in clinical reasoning. So I'll finish up today by returning to this question of sex and gender in the intensive care unit, and what do we mean by sex and gender when we're examining these concepts. And I said at the start that we often use the term sex and gender interchangeably in ICU. And so just to back up that statement a little bit, this is table 1 from our meta-analysis of sex differences in mortality. And we've audited, which term was used to describe the exposure of being a man or being a woman. And you can see that there were 10 of the 21 studies, 10 used the term gender, 10 used the term sex, and 1 used the term sex and gender. And I think I can understand this in that I think that what we're actually talking about reflects really aspects of both, biologically based sex and socially constructed gender, as sort of a sex-gender hybrid. My review of the literature, has demonstrated that really the existing literature only considers a binary definition of sex or gender, so really only compares women and men, and there's really no data that I could find on intersex, transgender or non-binary people in the intensive care unit. The adult patient database, so our clinical quality registry introduced a 3rd sex classification called the intersex classification in 2016, and that so the data first reported there in 2017. So we have a few years of data now, and we're doing some work to look at this population. At the moment, the intersex population within that clinical registry accounts for less than 0.1% of the data set, and this is likely to be unrepresentative compared to estimations of non-binary people in the population, which is estimated to be at least 1%. But in truth, I think that's also difficult to estimate based on current data. And I know, for example, both the Australian and New Zealand Bureau of Statistics are working on changes to the census process in our countries in how they record and report sex and gender. And so then this leads to the question, well, how did we actually identify sex or gender of our patients in the first place? And I think it's likely that in some cases it may have been a self-report, and even from a patient who's had a previous linked admission to that health service. If someone's coming critically ill, it may be a family or surrogate who's registered them at the hospital. It may be determined or designated by clinicians, or in fact clerical staff, so people at the front desk of the hospital or in the emergency room. So I think when we think about the future of sex and gender in critical care research, I think we need robust systems to identify sex and gender, including allowing people to identify their gender at hospital registration, so including non-binary genders. We absolutely need to have sex disaggregated data in all clinical trials. And we also need to look at the study populations of our critical care clinical trials to see if they have representative sex balance, representative of the ICU patient population. So to conclude this whirlwind tour of sex differences in the ICU patient population, I think the take-home points are that there are certainly more men than women in ICU. It's unclear if this represents equitable access to ICU. And when considering sex differences, diagnosis or admission diagnosis absolutely counts. We've seen that men get more treatment than women, but are roughly equally likely to die by hospital discharge. And I think the concluding point would be that if you have to get admitted to the ICU, you should try to have an illness that's common for your sex, and try to avoid being in any type of a sex-based minority group, as this is a higher risk category. And I'd like to end by acknowledging and thanking my PhD supervisors, co-authors on these papers, the ANZIC Centre for Outcomes and Resource Evaluation, which are the team that run the clinical registry I've spoken of, and probably most importantly, all the clinicians, data collectors and researchers across Australia and New Zealand that contribute to the adult patient database. So thank you very much, and I'm happy to take questions.
Thank you so much. That was an amazing lecture. Very, very interesting. I'd like to open it up to anyone if there's any questions that anyone has. please.
My hand, I don't know if you could see it.
Sure.
This
Dr.
is my-
Mehran, please go ahead.
Hang on, please ask.
Hi, congratulations on your wonderful work, especially the sex analysis, which I find fascinating. In our work with interventional procedures and in the highly sick individuals, and whether it's in the electrophysiology laboratory or even in the interventional suites, we are seeing less procedures. Women are underdiagnosed, undertreated, underreported, all of those things. And we put that very highly in our Lancet Commission when in 2021, when we published that with the commissioners, and we did have Gemma Figtree from Australia represented. And obviously when I see that we have a really important also sex-based differences and issues, and especially if we're not, these sicker patients are usually even more reluctant, and their assignment of their sex and gender is usually by administrators, as you actually said. And so to do these analyses, we really have to have intentional work, and perhaps not comparing men to women, but rather really taking a look at the diagnosis at hand and evaluating what we do with the diagnosis and the treatment approaches in women only, instead of comparing them always to men. Women are not smaller men. We have a lot of differences, and in fact, the confounders and the underlying diagnosis and risk always biases. And then of course, the physician's biases that you already brought up, biases whether or not these women would receive the therapies that are life-saving. For example, we have seen in the intensive care unit, well reported that cardiogenic shock patients who are women are less often receiving device-based therapies. And these are just, and probably because they're smaller, the devices are not made in pink and blue boxes for men and women, you know, they're made the same size for everyone. And we have smaller femoral arteries, all these other aspects. So how do you think, I mean, how I'm approaching this now in the next 2 years with the Lancet Commission is in developing think tanks in thinking about trials in women, rather than these meta-analyses, because we have to do 50 meta-analyses and 50 clinical trials to get a few women so we could see what's going on. But let's just exclude men. Sorry, but let's just think about women and what we're doing. Is that what you're thinking about, or in the intensive care unit? Or are we going to continue this, I call it nonsense, of just comparing men to women constantly? And I'll tell you, I had a lot of pushback when I first presented these data of just women with different levels of drug-eluting stents back to the Lancet. All of the reviewers came back to me and said, where are the men? We want to see how they're doing it compared to men. And I said, that's not my question. My question is, how are women doing with generation drug-eluting stents? Because we needed to get 21 randomized trials to get 11,000 women. So it is really an issue, and I just love this topic, and I think you did a beautiful, fantastic job. But I'd love to hear what you're thinking about for intensive care and what the next steps are there.
Yeah, thank you for that question. And look, the Lancet Commission, I think, is just wonderful work. So thank you for your work on that. I think this question of speaks to, you know, are there differential impacts of different treatments on women and men? And you're quite right. I think, you know, there's a range of different reasons why it may be that women, you know, have different outcomes following treatment. So for any examples of that in critical care are things like mechanical ventilation. There's you know, some nice work demonstrating that women are less likely to receive lung protective ventilation strategies, that they're less likely to receive sort of safe tidal volume for ideal body weight, which is possibly related just to the guesstimates on which we base, you know, or the default way that we may dial up a tidal volume. And I think the other examples you've given, you know, the size of arterial devices, we're putting a balloon pump in, ECMO cannula, things like that needs to be adjusted to appropriately to body size. There's actually, I think some years ago, there was just this lovely piece of work looking at aortic aneurysms in women and men and trying to understand the sex differences in outcome. One of the very simple conclusions from this person's PhD was that we needed to stop using a single cutoff. So I think this was at the time when they used a cutoff of 5 centimetres for everyone, and the fairly simple observation that 5 centimetres, a 5 centimetre abdominal aortic aneurysm may actually be, a really far more significant in a 50 kilogram woman than a 90 kilogram, 6'6" man. I have to say, in my work, I do take the approach of comparing men and women within the data sets. And I think because then that does allow us to tease out areas where there's differential impact. So I think if you can demonstrate, for example, that a woman is having a relatively worse outcome or indeed a better outcome following a certain intervention, I think that easily justifies a reason for providing them a more tailored response. I hear what you're referring to, potentially studies that would look at outcomes of women across, for example, different interventions. So I think in summary, I think there's probably a role for both approaches. But absolutely we need, if we are to continue comparing women and men, which I think there is a role for, we need to ensure that the study populations are actually representative of the clinical populations, and in situations where actually the sex balance strongly favours one sex or the other, then it may be that we need to have trials that look at just that minority group in order to get enough data.
Dr. Modra, Dr. Mehran, this is a perfect forum to introduce the two of you. Dr. Modra is a leader in what she just spoke about, and Dr. Mehran is the professor of cardiology and interventionalist. I don't know if you know each other, but she's a leader really in women's health, women's professional health as well, in cardiology and in the broader medicine area. So I think offline I will send an email to the two of you so you're introduced. And I thank you so much. It's 2 p.m. and I want to remind all the critical care folks to stay online as we start our research meeting. Thank you so much, everyone. Thank you, Dr. Modra. Thank you, Dr.
Thank you very much.
Thank you so much.